Hey guys, so today we're going to go over the rehabilitation frame of reference. So our course objectives for this is to describe the rehabilitation frame of reference in terms of its use and related tools and techniques. We want to recognize examples of when to use the rehabilitation frame of reference when appropriate, describe and recognize each of the following related to the rehabilitation frame of reference, which are theoretical assumptions, function and dysfunction, continuum, and indicators, as well as postulates regarding change. Then we're going to apply the rehabilitation frame of reference to a case study. So some basic concepts to know. So the rehabilitation frame of reference provides compensatory strategies. So we're using adaptive equipment, any type of education, as well as collaboration with their caregivers, the patient's caregivers. It's a theoretical basis and it uses systems theory. Systems theory is the influence of group on an individual's behavior. The system operates to maintain balance and an individual contributes to that balance. So an example of getting the flu shot, you get the flu shot, it will also protect your patient from getting the flu as well. Not only you, but your patient as well. It also uses learning. Some uses of the rehabilitation frame of reference is when recovery is expected, there's a temporary compensation parameter. So think of anyone that gets their hip replaced. I can give you an example of my father getting his hip replaced. When my father got his hip replaced, it was about, I think the doctor said 4 to 6 weeks of recovery. He was utilizing adaptive equipment as well as some compensation strategies to ensure that his precautions were actually followed. And this will go with any patient that you get with a certain replacement, whether that be a hip replacement, a knee replacement, rotator cuff replacement, anything like that. This can also be used for spines as well as immobilized upper extremities and what we quantify as a new CVA, so new cerebral vascular accidents. So we're not referring to those who have had a CVA before and then get a new one. We're referring to those who have never had a CVA before. We can also use the rehabilitation frame of reference when recovery is actually not expected. So when we're doing permanent compensation techniques. So some examples of some diagnoses you may see where we're constantly using different types of techniques for compensation, and it's more so for permanent technique. Think of your old CVA patients, patients that are suffering from dementia, patients with developmental disabilities, as well as multiple sclerosis. Can anyone think of any other examples of what type of diagnosis would need for a permanent compensation technique? Give you guys a second to think about it. So think of your traumatic brain injury patients, Parkinson's patients, arthritic patients, ALS, muscular dystrophy, and your spinal cord injuries. So those patients that aren't necessarily going to get better necessarily, but can use permanent compensation techniques to do what they need to do to live a successful life. So then we have some theoretical assumptions with this frame of reference. So independence can be regained using compensation when deficits cannot be remediated or during the remediation process in general. So when we're thinking of this frame of reference, think of a top-down approach for clinical reasoning. So the first focus is on the environment, then we're going to look at volition, and then habituation or habit, and that's followed by functional capabilities, and then we look at prerequisite skills and deficits. So when we think of a top-down approach, we're thinking from general to specific. We're also looking at environmental context as well in relation to that. Some more theoretical assumptions. So some necessary underlying skills. There should be like an emotional component as well as a cognitive component. So think of a patient, are they emotionally stable? Think of as far as cognition, like can they acquire new learning? Is what you're going to teach them going to be able to be utilized after the fact, or they're going to need constant repetitions to learn that activity or that compensation technique? So reasoning, we use the top-down approach is knowledge or expectations are used to guide the processing. So remember that top-down is moving from general down to specific. Excuse me. So then we're gonna look at function versus dysfunction. So we're looking at addressing ADL and IADL, work, leisure, and we're evaluated by observation and interview. So indicators of function are ADLs performed in a safe and timely manner. Let's think about the word timely manner. Any ideas of what timely manner might mean? So when we're considering timely manner, think about the average amount of time it takes for an average amount of normal time. I'm using normal in quotation marks. That's required to complete that task. We want to take that into consideration as well as the patient's deficits. And sometimes the time doesn't really matter, right? You're going to get your shirt on when you get your shirt on, type of thing. As long as the client can complete the task, and that's our main objective here. Same thing with IADLs. They are performed in a safe and timely manner with work skills that are effective for the demands of the job, and we want them to have the ability to participate in leisure activities. That's our main concern. We want to make sure that these patients are living their best lives. So some postulates regarding change. If a therapist uses various forms of compensation, then independence in ADLs and IADLs, home management, work, and leisure will be maintained. So you want to use as many different types of compensation as possible. Something may work better for one versus the other, and vice versa. So the therapist can use adaptive devices, wheelchair modifications, functional mobility aids, adaptive procedures, education, etc. You can keep using different ones and different techniques. Honestly, the more diverse the techniques, the better off the patient will be, and the better off you will be as a treating therapist. So you won't get bored teaching the same adaptive equipment over and over again, type of thing. So let's review today's objectives. We wanted to describe the rehabilitation frame of reference in terms of its use and related tools and techniques. We wanted to recognize examples of when to use the rehabilitation frame of reference if appropriate. We want to describe and recognize each of the following related to the rehabilitation frame of reference, which is the theoretical assumptions, function and dysfunction, as well as the continuum and indicators, and postulates regarding change. We also want to apply the rehabilitation frame of reference to a case study. Now, we haven't applied it yet, but for next class, I will have a case study printed for you guys that we will work on in class and kind of talk over that. Before we do that, I will set aside time in the beginning to clarify answers to questions about this PowerPoint, as well as review questions for this PowerPoint. Please let me know if you have any questions. Don't hesitate to reach out. If not, I will see you next week.